What if the conventional wisdom on fixing broken bones isn't quite right?
Mm-hmm.
Imagine looking at a classic medical text over 70 years old that suggests sometimes less is actually more.
Right.
That trying too hard to achieve perfect anatomical alignment can, counterintuitively, lead to a worse outcome.
It's a fascinating idea.
Welcome back to The Deep Dive, the show where we take a stack of sources, whether they're complex reports, foundational texts, or groundbreaking research, and extract the most important nuggets of knowledge for you.
Mm-hmm.
Our mission is always to give you that shortcut to being well-informed with surprising facts and enough context to make it stick.
Absolutely.
Today we're embarking on a deep dive into a fascinating piece of medical history that offers enduring lessons. Excerpts from John Charnley's seminal 1950 text, The Closed Treatment of Common Fractures.
A real classic.
It is. And this isn't just about old medical techniques. It's a deep look at fundamental principles of healing, mechanics, and biological reality that shaped how surgery evolved and still resonate today.
Definitely. It's about the thinking behind it.
It is, yes. It's about challenging assumptions and understanding the why. I'm joined, as always, by our expert speaker, a mind capable of synthesizing complex information and providing the essential context needed to navigate these deep dives.
It's a real privilege to explore this text. Charnley's work is, well, it's a brilliant example of rigorous observation and critical thinking applied to clinical problems.
It really is.
And its insights, I think, extend far beyond just the operating theater.
Absolutely. Reading this book, published right at the midpoint of the 20th century, you're struck by how much has changed in surgery, of course, but also how many of his core arguments feel incredibly relevant, even provocative today.
They do.
He was clearly pushing against the prevailing tides in some areas, wasn't he?
Or certainly. He wasn't afraid to challenge established views.
Let's jump straight into a rapid-fire setup then, pulling out a few high-impact points from the book to preview some of the fascinating angles we'll explore.
Sounds good.
First question, drawn from the very beginning of the book. Charnley dives straight into the difficulty of scientifically comparing conservative, closed methods of fracture treatment, things like manipulation and plaster casts, with operative surgical treatment.
Right, the classic comparison.
Exactly. Why was a true comparison based on hard data so challenging even back then, and what were some of the surprising downsides he highlighted about the surgical approaches prevalent at the time?
That's a crucial starting point for the book, really.
Yeah.
And it highlights the state of medical understanding and, well, research methodology back then in the mid-20th century.
How so?
Charnley is quite clear that a true, rigorous comparison was difficult because, well, as he puts it, the fundamental nature of fracture repair was unknown from a basic science perspective.
So they knew things healed, but not precisely how.
Exactly. Healing was observed clinically, of course,
Right.
but the underlying cellular, the molecular processes,
Yeah.
they were poorly understood.
Right.
So clinical practice was the primary, almost the only way to compare methods. But clinical results were plagued by variables.
Too many confounding factors.
Precisely. Think about the complexity. The degree of bone fragmentation, what's called comminution, where the bone shatters into multiple pieces.
Okay.
The presence or absence of infection, sepsis,
Hmm.
the specific surgical technique used, the surgeon's own skill.
Huge variables there.
Huge. And the patient's overall health, the blood supply to the bone, the location of the fracture itself, who was assessing the outcome. All these factors varied enormously.
So trying to pool results was almost impossible.
Well, it made pooling results from even a series of, say, 100 or 200 cases statistically insignificant when trying to draw firm conclusions about which method was inherently better.
Right. You couldn't isolate the variables.
Not effectively. And on top of this, he noted significant downsides to the operative treatments of the era. Early internal fixation involved implants that were mechanically limited.
They weren't strong enough.
He talks about the enormous forces that bones are subjected to, just through normal movement. And the metal implants of the time were prone to fatigue failure.
Meaning they just break.
They would break under repeated stress, often before the healing was complete.
Not ideal.
Not ideal at all. And, critically, there was a significant risk of sepsis infection associated with surgery. A risk that, according to Charnley, was greatly exacerbated by specific surgical steps.
Which steps in particular?
Particularly stripping away the periosteum from the bone surface,
Right.
that outer membrane.
Okay, we'll definitely come back to the periosteum. So, messy data, early tech with failure points. It paints a different picture than our modern assumptions about surgical certainty, doesn't it?
It really does.
Yeah.
A much less certain picture.
Second rapid-fire question then, and this relates to one of his core arguments. Charnley repeatedly steers attention away from the broken bone fragments themselves and towards something else entirely. What does he suggest is actually more important than those broken ends in guiding a successful fracture reduction?
This is where Charnley truly challenges the visually obvious, what you see on the X-ray. While X-rays show us the bone fragments clear as day, he argues that the supreme importance of the soft tissues is often forgotten precisely because they are radiotranslucent.
They don't show up well on the X-ray.
Exactly. Yet these soft tissues, the muscles, ligaments, the joint capsule, the periosteum we just mentioned, he presents them as secondary only to life itself in the process of healing. And critically, in guiding a closed reduction. When you're manipulating the limb without cutting it open.
So how do they guide it?
It's the undamaged soft parts, you see. The bits that aren't torn, they act like a hinge or a guiding tether. They provide the crucial clue to successful closed reduction.
Ah, right.
If you could manipulate the limb to bring these intact soft tissues back into their normal anatomical relationship, the bone fragments, even if you can't see them perfectly on an X-ray, will often just fall back into place. They follow the lead of the tissues, still holding things together.
That concept of the soft tissue hinge, of the invisible guiding the visible, that's incredibly powerful.
It really is a fundamental insight.
Okay, final rapid fire point. He also challenges assumptions about plaster casts and splinting. What's a key takeaway from the book about how a plaster actually works, or perhaps how it doesn't work, in providing fixation?
Right. The plaster cast.
Yeah.
The common image is one of absolute rigidity, isn't it?
Yeah.
Holding everything perfectly still.
Yes, like concrete.
But Charnley explains that a plaster functions not just as a passive mold, but through what he calls a three-point system.
3 points.
Yes. Imagine applying force at 3 specific points. 2 points on one side of the limb and a third point on the opposite side, usually right at the level of the fracture, pushing against the other 2.
Okay, I can picture that.
This system exerts counterpressure to maintain alignment, which is why the molding of the plaster as it sets is so important.
Ah, it's not just wrapping it on.
Not at all. Sometimes you need a plaster that's actually slightly curved to hold a straight bone in place because of the forces it needs to exert.
Okay, but you said how it doesn't work too.
Yes, and this is the critical point. Even the most meticulously applied, skin-tight plaster only provides relative immobilization.
Relative, not absolute.
Not absolute, no. True, absolute immobilization, eliminating even microscopic movement at the fracture site. That's only possible with internal fixation metal plates or rods inside the body.
Why can't plaster achieve that?
The reason is the movement that occurs between the skin and the skeleton. The skin moves relative to the bone underneath, doesn't it?
Yes, a little bit.
And the plaster is essentially fixed to the skin. So any skin movement means some movement potential at the fracture. He points out that even with a wrist fracture cast, a patient can often still manage half an inch or so of wrist movement.
I never thought of it like that.
And he's particularly, quite scathing about walking plasters for foot fractures, things in the tarsus or metatarsus.
The bones in the midfoot and towards the toes.
Exactly. He basically says they are no more effective than a leather boot for immobilizing the bone itself.
Really? That's strong.
Yes, because as you bear weight, the soft tissues of the sole compress, the foot arches deflect. There's movement, regardless of the cast. The cast is just a shell around a structure that's inherently moving internally under load.
So even something we see as incredibly solid, like a plaster cast, is presented as only providing relative fixation due to the very biological reality of skin and tissue movement.
That's his argument, yes.
That genuinely makes you look at a cast differently. Okay, fascinating groundwork laid. Let's unpack this further and move into our first major segment. Foundations and fundamentals, delving deeper into the underlying biological and mechanical principles Charnley explores in the book.
Absolutely. The book really starts by looking at the fundamental nature of bone healing, a process that, you have to remember, was still being actively researched and debated in his time.
Right.
He touches on the different types of bone tissue woven bone, which is the initial, maybe slightly hurried, provisional bone laid down quickly after injury. It gives early stability.
Like a quick patch job. Sort of, yes. And then there's lamellar bone, which is the stronger, more organized, layered structure that forms later. It needs that initial woven scaffold to mature properly.
Okay.
Think of woven bone as maybe the temporary scaffolding put up quickly on a building site.
Right.
And lamellar bone as the eventual reinforced concrete structure being carefully built layer by layer upon it.
That's a helpful analogy. And this is where he introduces his strong emphasis on the periosteum, isn't it? You mentioned it earlier.
Yes, he comes back to it again and again.
Why is this membrane covering the bone so central to his argument, particularly when comparing open surgery to closed methods?
Precisely. The periosteum is this layer of connective tissue covering the outer surface of most bones. It has an inner layer containing cells that are crucial for bone formation, osteoprogenitor cells, they're called.
Bone-forming cells.
Essentially, yes. And Charnley places immense importance on it because he views it as a site with a remarkably free and active blood supply.
That makes it a powerhouse for generating callus. Callus is the body's natural biological cement, the new bone tissue that bridges the fracture gap and eventually forms a solid union.
Right, the bulge you sometimes see on x-rays.
That's often it, yes.
Mhm.
And he contrasts the vitality of the periosteum with the fractured bone ends themselves, especially in the shafts of long bones in the cortical bone.
Why, especially there?
Because a primary blood supply in cortical bone runs longitudinally through tiny channels called haversian canals. When a fracture occurs, that longitudinal supply is interrupted right at the break.
Ah, so the very ends lose their direct supply.
Effectively, yes. His figure 13 in the book is very illustrative. It seems to show vigorous new bone growth arising from the periosteum, while the fractured bone end itself looks almost, well, inert by comparison in the early stages.
Inert. That's a strong word.
It is. He's making a strong point about where the biological activity is primarily coming from initially.
And he talks about a shibboleth regarding periosteal callus. What was the debate, the sort of ingrained belief that he was challenging there?
Ah, yes, the shibboleth. It's an old belief or custom, often outdated.
Okay.
This referred to a significant philosophical divide amongst surgeons of the time. One prominent view, often associated with proponents of rigid internal fixation, like Lane and Sherman earlier in the century.
The pioneers of plates and screws?
Exactly. They saw extensive periosteal callus formation, that bulge we mentioned, as a sign of inefficient healing, almost a pathological response.
Why?
They believe that ideal union should happen directly between the perfectly coapted bone ends, what's sometimes called primary bone healing, though the understanding of this was still developing.
End-to-end healing, a minimal external callus.
That was the ideal they were aiming for. They observed that after open reduction, where the bone ends were meticulously exposed and stripped of periosteum to achieve perfect anatomical alignment and apply plates, there seemed to be less visible periosteal callus on the X-ray afterwards. And they interpreted this absence of callus as evidence that their technique was achieving this ideal inter-end union.
But Charnley disagreed.
Vehemently. He argues completely against this interpretation. He insists that the early, fluffy, hazy periosteal callus, looking like a cloud on the X-ray, as shown in his figure 20A, is actually a sign of healthy, vigorous biological repair.
So a good sign.
A very good sign, in his view. And he claims it is never seen after open reduction where the periosteum has been deliberately stripped away, as in figure 20B. He argues that stripping the periosteum removes or severely compromises this vital source of early callus formation.
So the surgical technique aimed at perfection on the X-ray was, according to Charnley, actually interrupting a fundamental biological pathway for natural healing.
Precisely his point. And this ties directly into his deep concern about sepsis infection in operative fracture treatment.
How so?
He argues that stripping the periosteum abolishes the vitality of the bone surface. It damages its local blood supply and removes those crucial bone-forming cells.
Right.
This creates an environment highly favorable for infection to take hold and persist, especially when you introduce a metallic foreign body like a plate or screws right into that site.
Makes sense.
He suggests that many cases of delayed union or non-union following internal fixation in that era might actually have been due to deep, perhaps low-grade infection that later subsided, but which had rendered the stripped ischemic bone surface essentially lifeless, preventing it from participating properly in the healing process.
Lifeless. That's a chilling. This is where he brings in those rather morbid but incredibly powerful historical examples, isn't it? John Hunter's specimens from centuries earlier.
Yes, it's a remarkable rhetorical move, isn't it? A leap back in time to make a crucial point about the present was present in 1950.
What were these specimens?
He discusses John Hunter's specimens from the late 18th century, specifically these things called coronet or ring sequestra found in old infected amputation stumps.
Sequestra.
A sequestrum is a piece of dead bone that has become separated from the surrounding healthy bone during necrosis.
Okay. So dead bone, rings, and amputation stumps.
Yes. Charnley argues that an amputation is essentially the proximal half of a compound fracture. The bone end has been cut and exposed. In infected stumps from that era, a ring of dead bone often formed right at the cut end.
And his interpretation?
He interprets this as a zone of cortical bone that was made ischemic, losing its blood supply, both by the saw cut, which interrupts the longitudinal supply in the Haversian canals,
Right.
and by the surgical stripping of the periosteum, which was standard practice.
Yeah.
If infection then sets in, this already compromised ischemic bone becomes irreversibly killed.
A double whammy.
Exactly. These specimens, preserved for nearly 200 years, served as vivid evidence for Charnley of the futility of expecting the ends of cortical bone to join when they're coapted or compressed together under conditions where their vitality is compromised.
So trying to force dead ends together won't work.
Essentially. They show that while callus might form externally, maybe from deeper tissues or surviving periosteum further away, it cannot reach or incorporate a truly ischemic bone end. It's a stark demonstration of how stripping the periosteum, especially with infection, can turn a living structure capable of repair into something like, well, he provocatively describes it as inert mineral substance.
Inert mineral substance. Wow, that connection, spanning centuries using anatomical specimens to argue a point about contemporary surgical technique, it really underscores his analytical approach, doesn't it?
It absolutely does. He's thinking biologically, historically, mechanically.
So if these cortical bone ends can become almost inert, particularly after stripping an infection, how does successful healing actually occur in the shafts of long bones, according to his view, if the ends aren't the main players initially?
This leads into his principles of union, and distinguishing between different bone types is key here. Cancellous bone, the spongy bone found at the ends of long bones near joints that has a rich, profuse blood supply. That type of bone heals rapidly, particularly with compression. Cortical bone, forming the dense shafts, is different. As we mentioned, its blood supply is primarily longitudinal through those narrow Haversian canals.
Right.
At the moment of fracture, a significant portion of the cortical bone right at the break is functionally, well, almost inert mineral compared to the truly living cellular elements elsewhere.
So what needs to happen?
For normal healing in cortical bone, these Haversian vascular channels need to enlarge. The dense cortex needs to become more porous, biologically active, allowing blood vessels to penetrate from the surrounding healthy areas and bring in healing cells.
Like opening up pathways.
Exactly. And Charnley, citing the work of Ham, another researcher, shows how stripping the periosteum severely impedes this necessary process of vascular channel enlargement and cortical remodeling. The bone ends remain dense, less biologically receptive.
So stripping hinders the bone's own ability to prepare for healing.
That's the argument. This insight is fundamental.
Yeah.
For cortical bone, the biological factors, the vascularity, the health of the periosteum are paramount, perhaps even more so than the purely mechanical act of rigidly holding the ends together, at least initially.
Which supports his case for conservative treatment first.
It supports his argument for potentially delaying operative treatment in many cases, allowing biological recovery and callus formation to begin under less invasive conservative management first, preserving that crucial biology.
That really challenges the intuitive idea that you just need to hold the pieces together tightly as soon as possible. He's saying the biology has to be right first.
The biology is king, in his view, for cortical bone healing.
And he uses these powerful, even quite blunt propositions to compare operative and conservative methods from his perspective in the 1950s.
Yes, he doesn't pull any punches at all. His propositions are quite stark.
What are they?
First, operative treatment is potentially harmful to all fractures in the sense that it introduces inherent risks like infection and disruption of biology. Conservative treatment, in contrast, is harmful only to a few fractures or patients, those where it's clearly unsuitable or perhaps mismanaged.
So surgery is always risky, conservative only sometimes.
That's the gist of the first point. Second, the few cases harmed by conservative treatment might have been less harmed by operation. But he suggests this is debatable and actually quite hard to prove definitively.
Right.
And third, perhaps most critically, the failures resulting from operative treatment and those from conservative methods are not equally capable of being salvaged by secondary procedures.
Not equally salvageable.
He called this the critical point. His view is that complications from operative treatment, especially severe deep infection involving metalwork and dead bone, well, they could be catastrophic. far more difficult, if not impossible, to recover from.
Compared to?
Compared to the issues typically encountered with conservative management, like maybe delayed union or some degree of deformity, these might still be addressable with safer, less invasive later procedures like bone grafting, which we'll come to.
So it's a calculation of risk versus reward, prioritizing salvageability over the potentially disastrous consequences of an early, risky intervention. It's about avoiding burning bridges, essentially.
That's a very good way to put it. Avoid burning the biological bridges.
And building on this idea of trusting biology and prioritizing the less destructive approach, he loops back to the art of closed reduction and that soft tissue concept you introduced earlier.
Yes, he dedicates significant space to explaining the mechanics of closed reduction. He considers it an art, requiring the surgeon to build accurate mental pictures of the injury and the surrounding anatomy.
Not just looking at the X-ray.
Not just staring at the X-ray shadows, no. He reiterates that supreme importance of the soft tissues. The broken bone fragments are, in a sense, just indicators. The real guide to reduction lies in understanding the state of the damaged and, crucially, the undamaged soft parts.
The intact ligaments, muscles.
Exactly. Intact ligaments, joint capsules, or strips of periosteum can act as a strong guiding hinge.
Like his jigsaw puzzle analogy for the Potts fracture, you mentioned that.
Exactly that analogy. A Potts fracture. A common ankle fracture, often involving the malleoli, those bony bumps on either side, and ligament tears. It can look like a bewildering mess of bone fragments on an X-ray. Trying to reduce it by focusing only on aligning the bones feels, he says, like trying to solve a jigsaw puzzle in the dark.
Right.
The key is to appreciate which soft tissues are still intact. If you can manipulate the ankle to restore the normal relationship of the parts still held together by these intact ligaments or capsule, the bones will often naturally follow.
He has a model for this, doesn't he?
Yes, a simple but effective model of two pieces of wood joined by a leather strip. It shows how this soft tissue hinge works.
How?
You can manipulate the pieces, perhaps even applying forces that initially increase the deformity slightly to put tension on the hinge of the leather strip. This tension then guides the bone, ends back into alignment, and can even create compression at the fracture site when the hinge is taut. Figure 41 illustrates this visually, and Figure 54 provides clinical X-ray evidence in a slipped epiphysis, a growth plate fracture, showing the periosteum ossifying on the concave side of the deformity, acting as a biological tether.
It sounds like reduction isn't just about brute force or simply pushing bone fragments around. It's about understanding and leveraging the remaining biological structure.
Precisely. It's finesse guided by anatomical understanding.
And this applies to traction methods as well, pulling on the limb.
Fundamentally, yes. Traction, whether it's skeletal traction applied through a pin in the bone or just skin traction with tapes. It works by creating tension in the surrounding soft tissues.
Okay.
This tension helps to pull the displaced fragments back towards their normal length and alignment. Continuous traction, like that used traditionally in a Thomas splint for a femur fracture, provides what he calls relative fixation. Yes, it's rigid and holds alignment when the tension is maintained, but it allows some flexibility or movement if the tension is released or overcome. He uses the analogy of a chain in tension.
Interesting. He mentions his wartime experience influencing his views on traction.
He does. He initially favored fixed traction to absolutely prevent any distraction or pulling apart of the fragments, but later he accepted that balanced traction using weights was effective too. He concluded that the harm originally attributed to weight traction ought to be transferred to the rupture of the pathways which conduct osseous union. Meaning it wasn't the gentle distraction itself that was the main problem, but rather using excessive or inappropriate force that could tear those vital soft tissue pathways needed for healing. The biology again.
What counteracts this traction, making it difficult to achieve length sometimes, even under anesthesia? Is it just muscle spasm?
Muscle tone is certainly a factor, but Charnley argues it's often not the most significant barrier, especially in the acute phase.
What is then?
He highlights what he terms a hydraulic element in limbs that are grossly swollen with large effusions of blood and fluid.
Hydraulic?
Yes. The fibrous compartments within the limb become distended and tense, like an overinflated tire. This resists any attempt to lengthen the limb. The limb naturally tends to adopt a more spherical shape, which holds the greatest volume for a given surface area, but corresponds to a shorter overall length.
Ah, so the swelling itself fights against the traction.
Exactly. Allowing time for this acute swelling to subside naturally can significantly facilitate reduction later on.
Anything else resisting traction?
Yes, there's also resistance from interlocking soft tissues, or sometimes even interlocking jagged bone fragments. Someone called Beveridge Moore demonstrated experimentally that sometimes you might need to slightly increase the deformity or angulation of the fracture first
Increase it. Why?
to unlock the fragments before applying traction. Applying violent, excessive traction before unlocking or addressing that hydraulic swelling could actually be harmful.
How?
By rupturing those remaining intact soft tissue strands, the very hinges you are relying on for guidance and stability. He suggests this mechanism might even contribute to non-union in some cases.
So, the art of close reduction involves not just mechanical forces, but a deep understanding of the limb's soft tissue envelope, its biological response like swelling, and the delicate balance required to leverage the body's inherent structures for healing. It's quite complex.
It's deceptively complex, yes. It requires real thought and feel, not just brute strength.
It really transforms your understanding of fracture healing, doesn't it? Charnley isn't just talking about bones. He's arguing that the invisible elements, the vitality of the periosteum, the guiding tension of intact soft tissues, the complex biological response to injury are fundamentally more important than simply forcing broken bone ends together.
That's the core of his argument about biology.
It's a powerful reminder that biological systems heal themselves, and sometimes our interventions need to respect and facilitate that process rather than override it.
Well said.
That was a truly foundational exploration. Let's transition now, maybe take a breath, and move into our second deep dive segment. We'll examine some specific techniques, challenges, and common fracture examples through the lens of Charnley's principles. You mentioned the three-point plaster system earlier. Could you elaborate a bit more on the practical application? How does a surgeon actually create these 3 points of pressure to maintain alignment when they're putting the cast on?
Certainly. The three-point system is really where the art of plaster molding comes into play. It's not just wrapping.
Right.
When applying the wet plaster bandage, the surgeon needs to actively mold it around the limb with their hands to create specific indentations and points of counterpressure.
Can you give an example?
Okay, say you have a forearm fracture that tends to angulate, to bend in one direction. You would mold the plaster to press firmly on the limb below and above the fracture site on the side it's bending towards.
Okay, 2 points.
And then you'd apply firm counterpressure with the heel of your hand on the opposite side of the limb, usually right over the apex, the peak of the fracture bend.
The 3rd point.
Exactly. It's this skilled manual pressure, applied while the plaster is still wet and hardening, that builds this internal framework of forces within the cast. Forces that resist the deforming tendency of the muscles or gravity.
Which is why you said sometimes a curved plaster holds a straight bone.
Precisely. To correct an angulation, you might deliberately mold the plaster into a curve, even though the bone inside is meant to be straight. The plaster's shape dictates the forces it exerts internally.
And this is why he argues the difference between padded and unpadded plaster is just a matter of degree in terms of immobilization, not a fundamental difference.
Exactly. Whether you have a layer of padding underneath or the plaster is applied directly to the skin, perhaps over a thin stockinette. The principle remains that the plaster is essentially conforming to and fixed to the skin. And since the skin is mobile relative to the underlying skeleton, the bone, as we established, any movement of the skin translates into some degree of potential movement at the fracture site, even within the tightest cast. An unpadded, skin-tight cast minimizes this movement more than a padded one. Sure, it provides a greater degree of relative immobilization, reducing that microscopic motion.
But neither is truly rigid.
Neither achieves the absolute zero-motion rigidity of internal fixation, which directly stabilizes the bone fragments themselves. This distinction is absolutely key. Plaster provides relative immobilization, which is often sufficient for many fractures to heal perfectly well, but is not truly rigid in an engineering sense.
And that distinction seems particularly relevant when he discusses walking plasters, especially for foot fractures. You were quite emphatic earlier.
Yes, his views on walking plasters for fractures in the tarsus, the ankle bones, or the metatarsus, those long bones in the foot leading to the toes, are quite definitive. He argues that expecting a plaster to rigidly immobilize these fractures while the patient is actually walking on the foot is, well, he uses the word futile.
Futile. Strong stuff. Why?
Because as weight is applied, the soft tissues of the sole compress significantly. The arches of the foot flatten or deflect. There's inherent flexibility and movement within the foot structure itself.
Right.
And this movement translates to movement at the fracture site, regardless of the outer plaster shell. It can't prevent that internal deformation under load. He observes that patients with these fractures instinctively walk on their heel initially anyway.
Protecting the front of the foot.
Exactly. They effectively use the walking plaster more like a protective boot to shield from direct knocks, rather than as a rigid splint for the fracture site itself.
So the common fear then that a fracture will inevitably displace further, get worse, if it's not rigidly splinted, that isn't universally true according to Charnley.
Not universally, no. He distinguishes between different fracture types and locations. For long bone shafts, say in the thigh or upper arm, with significant leverage and strong muscle pull, yes, spontaneous increase in deformity will likely occur if they're left unsupported. The forces are just too great. But for many short bones, or certain fracture patterns, even in long bones, where there isn't much muscle pull across the break, he argues the extent of tearing of the tough surrounding fibrous tissues like ligaments or joint capsules is what determines the maximum possible displacement.
So it displaces initially and then stops.
Often, yes. Unless further significant trauma occurs, the displacement won't worsen beyond this initial level dictated by the soft tissue envelope. The role of a splint or cast in these cases is primarily to prevent recurrence of the initial displacement after you've reduced it,
Right.
not necessarily to halt an ongoing, inevitable process of worsening deformity that doesn't actually exist in those cases.
Does he suggest that plaster actually speeds healing? Or is that another assumption he challenges?
He seems to counter the fear that a fracture will simply fail to unite, go on to non-union or pseudoarthrosis without immediate rigid splinting. He suggests this fear is often unfounded, particularly in short bones like finger bones, phalanges, or miniature long bones, where significant gross movement isn't typically the main issue limiting union.
But there are exceptions. Important ones.
Critical exceptions. He highlights fractures prone to ischemic necrosis.
Ischemic necrosis. That's where the blood supply is compromised, leading to bone death. We touched on this with the periosteum stripping.
Exactly the same principle, but caused by the fracture itself disrupting key vessels. He points to fractures of the scaphoid waist, or proximal pole, that's a small bone in the wrist, and specific types of femoral neck fractures high up in the hip, joint mid-cervical or subcapital types, as prime examples.
Why those specifically?
Because the anatomy is such that the fracture line can easily sever the main artery supplying blood to one of the fragments. This leads to a vascular necrosis or ischemic necrosis. The bone fragment dies.
Right.
Charnley insists this is a complication of fracture repair, a failure of biological supply, and must be distinguished from the healing of normal fractures where blood supply remains intact.
Are there other sites prone to this?
Yes. He mentions the talus, an important ankle bone, the medial malleolus, that inner ankle bone, and sometimes certain fractures near the wrist in the distal tibia or ulna.
So for these specific ischemia-prone fractures, what's needed?
For these, he states that rigid fixation is essential.
So here rigidity matters.
Yes, but critically, not necessarily, because it speeds normal bone healing per se. It's essential because the ischemic dying fragment needs a completely stable, rigidly held environment in close apposition to the healthy living bone on the other side of the fracture.
Why?
To allow for slow revascularization, for new blood vessels to gradually grow into the dead fragment from the living side, and for the body to slowly replace the dead bone with new living bone, a process called creeping substitution. The host bone needs that absolute stability to carry out this slow repair and incorporation process.
That's a really important distinction. Rigid fixation isn't a universal accelerator of healing, but it's specifically necessary to create the stable conditions needed to salvage and revascularize a compromised fragment in certain predictable locations.
Precisely.
Yeah.
It's targeted, based on biological risk.
What about joint stiffness after fractures? That's a common problem. He seems to challenge simple explanations for that as well.
He does. He's very wary of overly simplistic, mechanistic analogies for joint stiffness. Comparing joints to rusty hinges or engine bearings that just need lubrication or forcing to get them moving again.
Right, the no pain, no gain physio approach sometimes.
He views joint stiffness after fracture or immobilization as a process of great biological complexity. It involves not just the joint surface itself, but all the surrounding soft tissues, the capsule, ligaments, muscles, tendons, which can become scarred, thickened, or adherent to each other, or the bone.
So it's more than just the joint surfaces.
Much more. He discusses Böhler's controversial teaching from Vienna. Böhler claimed that prolonged fixation in a skin-tight plaster wouldn't cause permanent stiffness.
Really?
If the joints were placed in an optimum position within the cast and crucially, if the patient actively used the limb musculature within the cast, doing static muscle contractions.
Why would that help?
The theory was that muscle activity helped pump away swelling and fluid, which was thought to contribute to the formation of adhesions and scar tissue. Bowler went quite far with this, claiming patients could leave his plaster cast with minimal disability, even perform heavy work while still in casts.
Did Charnley agree?
He acknowledges that Bowler's methods had great content of fundamental truth, particularly regarding the benefit of early activity in minimizing stiffness. Many joints do recover full range over time with mobilization. However, he notes that Bowler's overall teaching ultimately failed in practice, not primarily because it caused permanent stiffness, but because it didn't eliminate the problem of delayed union in certain difficult fractures. The biology of bone healing sometimes trumped the prevention of stiffness.
Interesting balance. What does Charnley see as the worst cause of stiffness?
He points out that severe sepsis, deep infection, is the commonest cause of irreparable permanent joint stiffness because it leads to such extensive, dense scar tissue formation involving everything around the joint. Biology again.
So, just trying to mechanically force a stiff joint might not be the right approach if the problem is actually complex biological scarring.
That's the implication. A purely mechanical view might be insufficient or even harmful.
He gives these striking examples, doesn't he? Like the elbow and the heel bone, the os calcis, where attempting perfect anatomical reduction surgically seems, in his view, to lead to a worse functional outcome than a less perfect but more biologically friendly approach.
These are perhaps the most powerful illustrations of his less is more argument in specific clinical situations.
Tell us about the elbow first.
For complex elbow fractures, things like Y-shaped fractures of the lower humerus or certain radial head fractures, Charnley observes that the elbow almost invariably does badly after operative treatment.
Does badly, meaning stiff.
Stiff, yes, often with significant loss of flexion or extension. He contrasts this with the results reported by Eastwood, who treated complex Y-shaped fractures conservatively with early mobilization, even accepting some displacement on the X-ray, yet achieved reasonable function.
Better function despite less perfect anatomy.
That's what the evidence suggested. Charnley admits that in his own experience, even when he achieved exact restoration of anatomy surgically in the elbow, the end result in terms of movement was often similar to, or sometimes even worse than, the outcomes from conservative methods.
Why would that be?
He concludes that stiffness in the elbow is likely due more to scarring and contracture in the soft parts, the joint capsule, the ligaments, the muscles around the joint, rather than simply the configuration of the joint surfaces after healing. Surgery, especially extensive surgery, inevitably adds more scarring.
So the surgical trauma itself contributes to the stiffness.
That seems to be his interpretation. He even suggests that excision of the radial head, a procedure often done perhaps too readily even for minor crack fractures, might actually delay mobilization by causing more bleeding and reaction.
Any solutions for elbow stiffness?
He proposes that a single, forceful late manipulation under anesthesia might sometimes be effective for persistent stiffness after about 3 months. But he cautions strongly against repeated manipulations, which he felt just caused more damage and scarring.
Okay. And the os calcis, the heel bone, seems to be his ultimate case study in overtreatment. Why was that?
He presents the os calcis fracture as an instructive object lesson in the pitfalls of aggressive intervention aiming for anatomical perfection.
These are nasty fractures, aren't they? From falls.
Often, yes, falls from a height. They're complex, frequently involving crushing and impacting of the bone, particularly affecting the crucial joint it forms, with the talus above it, the submastogalloid joint, which allows side-to-side foot movement.
And the conventional wisdom was to try and fix it perfectly.
The drive was often towards restoring the anatomical shape, but Charnley states unequivocally that attempts to restore the anatomy of the os calcis almost invariably results in a stiff subastragalloid joint and a painful subastragoid joint.
Stiff and painful despite perfect reduction.
That was his observation. He cites the universally poor results achieved with Bowler's skeletal traction technique for these fractures, putting a pin through the bone and pulling. This often resulted in delayed consolidation in a distracted position, pulling the fragments apart slightly rather than the naturally impacted, crushed state.
So what was Charnley's counterintuitive finding?
His finding, based on his observation and experience, was that early mobilization of the fracture in its impacted position led to better results.
Mobilization, meaning getting the patient moving.
Yes, allowing the patient to move the ankle and foot gently, as comfort permitted, effectively walking carefully on the bruised, slightly collapsed heel bone with minimal support, perhaps just a protective bandage, or a boot, not rigid immobilization.
Accepting the deformity.
Accepting the impacted deformity. He found this led to faster recovery, less pain, and better overall function. Often, this conservative approach made late surgical fusion of the painful subastragaloid joint unnecessary, whereas it was frequently required after failed attempts at anatomical reduction.
Why did trying to reduce it make things worse?
He argues that attempts to pull the fracture out to length often disrupted areas where fibrous union, the initial scarring, had already started to occur naturally in the impacted position. This created cavities that filled with blood clot in the reduced state, which actually delayed bony union and increased scarring right in that critical joint.
Fascinating. Almost like leaving well enough alone was better?
In this specific complex fracture, that seemed to be the case. He also highlights the negative psychological impact. If a surgeon gives a gloomy prognosis for this fracture, which was common, that could contribute to poor outcomes. He suggests a more positive approach, encouraging early function, is beneficial both physically and mentally.
That's a powerful argument for prioritizing function and patient recovery over chasing anatomical perfection on an X-ray, especially when the anatomy is complexly shattered.
Absolutely.
It's a lesson that resonates beyond orthopedics, surely knowing when not to intervene too aggressively.
Indeed. The examples of the elbow and os calcis are profound, really. They challenge that intuitive assumption that perfect anatomical restoration automatically equals perfect function.
Right.
Charnley shows how disrupting the biological environment, or the natural, albeit imperfect, state of the injured tissues through aggressive surgery, well, it can lead to more scarring and worse functional outcomes than accepting some anatomical imperfection. But facilitating early biological recovery and functional adaptation through conservative means.
It's a vital lesson.
It is a lesson in understanding the intricate relationship between structure, function, and the body's own healing capabilities.
Beyond these major principles and case studies, he also includes numerous practical tips on plaster technique throughout the book, doesn't he? Small details that reinforce the underlying mechanical principles we discussed.
Absolutely. He gets right down into the practical how-to of applying a good cast, which was obviously central to his practice.
Like what?
For instance, emphasizing the need for an end-to-end rhythm when applying the wet plaster bandages, rolling them on smoothly and evenly.
Why is that important?
To ensure even thickness and a consistent feel along the whole functional length of the cast. No weak spots, no overly thick areas, just good craftsmanship.
Makes sense. Any other examples?
Yes, the importance of molding forearm plasters into an oval cross-section rather than just a round tube.
Oval. Why oval?
Well, the bones of the forearm, the radius and ulna, lie side by side. An oval mold helps maintain the natural space between them, the interosseous space, and it facilitates better control of rotation pronation and supination. A simple round plaster might tend to squeeze the bones towards each other, which isn't ideal.
Subtle but important.
Very. He also details techniques like wedging a plaster to correct any residual angulation after it's set.
How does wedging work?
You essentially cut the plaster almost all the way through on the side towards which the angulation needs to move, the concave side. Then you open up a wedge-shaped gap by cutting out a larger piece on the opposite side, the convex side. Then you manipulate the limb to close the first cut and open the wedge, correcting the angle, and hold it there with a new wrap of plaster. It maintains the three-point fixation principle.
Clever, like fine-tuning the alignment.
Exactly. And he also advises splitting plasters longitudinally down the side after procedures like bone grafting.
Why split them?
To prevent pain and circulatory compromise due to the inevitable post-operative swelling. It allows the limb to swell slightly without the cast becoming dangerously tight, ensuring the biological healing process isn't impeded by external pressure.
Practical considerations for biological processes. He also mentions the classic Thomas splint for femur fractures, still used sometimes today, isn't it?
Less commonly now with modern surgical fixation, but yes, historically it was a mainstay of conservative femur fracture management for decades. Particularly valuable during wartime due to its relative simplicity and effectiveness with either fixed or balanced traction.
What were the challenges with it?
He described its use and the common issues, such as managing the pressure from the padded ring at the groin, which could cause sores. He mentions using counterpoising techniques to help manage that. And he reiterates the ongoing debate from that time around early knee movement while the femur fracture was healing in the splint.
The stiffness versus healing debate again.
Precisely. Functionally appealing to start moving the knee early to prevent stiffness, but potentially risking some loss of position or distraction at the fracture site, or even leading to a late varus deformity, a bowing of the thigh bone.
Always trade-offs. And wrapping up our look at specific fractures, the Pott's fracture of the ankle, which you said earlier he seems to approach with a certain fondness.
He does seem to describe the pleasure of reducing a Pott's fracture once you truly understand its mechanics, contrasting it with the frustration he felt in earlier attempts before he fully grasped the principles involved.
And it's a prime example of the soft tissue hinge concept.
Absolutely. He stresses that in the common type of injury, an external rotation type, the ligaments on the medial, the inner side of the ankle, often remain intact even if the bones are broken. These intact ligaments are the key.
So how do you use them?
By manipulating the foot, often using gravity or a specific support position, perhaps an internal rotation, and some supination turning the sole inwards and maintaining pressure, you can leverage these intact structures, put tension on them, to guide the talus, that's the main ankle bone that sits above the heel bone, back into its proper relationship underneath the tibia, the main shin bone.
And the broken bits follow?
And the fractured malleoli, the bony knobs, will generally follow the talus back into a good position. He notes that slight displacement of the posterior malleolus, the back part of the tibia at the ankle joint, is often acceptable.
Even if it's not perfectly aligned?
Yes, if the main ankle joint itself, the relationship between the talus and the tibia, is well reduced and stable. Again, favoring functional alignment of the main weight-bearing joint over perfect anatomical alignment of every single fragment.
And traction isn't usually needed here.
Skeletal traction is rarely needed for these ankle fractures. In his view, if the manipulative technique, based on understanding the soft tissues, is mastered.
It's clear this book is just a masterclass in observation, mechanics, and challenging assumptions, isn't it? Drawing on history from Hippocrates' ancient principles of reduction right up to John Hunter's specimens to inform contemporary practice.
It really is a synthesis of observation, biomechanics, and historical perspective.
And it's perhaps fitting that Charnley's later, arguably more famous work, the development of the modern low-friction hip replacement. Well, that work is associated with the John Charnley Trust's pioneering emphasis on decades-long patient follow-up, 30-year follow-up as a gold standard. It reflects that same commitment to rigorous, long-term evaluation of outcomes that he implicitly advocates for when discussing the difficulties of comparing treatment methods right at the start of this book on fractures.
A very consistent philosophy throughout his career, yes.
That was a truly expansive deep dive, covering fundamental biology, practical mechanics, specific fracture examples, all through the lens of a classic text that really challenges us to think critically. Let's try and distill some of the core ideas in a quick lightning round. Ready?
Ready.
First, name one key anatomical structure Charnley emphasizes as being more important than the bone fragments themselves in successful closed reduction.
The intact soft tissues ligaments, periosteum acting as a hinge or guide.
According to the book, what's a key biological risk associated with stripping the periosteum during open surgery?
It compromises the blood supply to the bone surface, damages its vitality, and increases the risk of persistent sepsis, which impedes callus formation.
What's the striking counterintuitive finding from the book regarding the treatment of severe heel bone, os calcis, fractures?
That early mobilization in the impacted position, accepting the deformity, often yields better functional results than attempts at anatomical restoration or using traction.
Charnley describes something as the greatest advance in tibial fracture treatment in the 50 years prior to his writing. What was it?
The Femister bone graft technique, applying thin slices of the patient's own bone onto the surface of a delayed union site to stimulate healing.
A concept challenging the idea that a plaster cast provides absolute rigidity.
The three-point system, combined with the principle of relative immobilization, limited by the movement between the skin and the skeleton.
And finally, beyond anatomy and mechanics, what did Charnley suggest contributed negatively to outcomes in those difficult os calcis fractures?
The surgeon's own gloomy attitude towards the injury, which he felt could negatively impact the patient's psychological state and potentially hinder their recovery.
Those quick points really highlight the sheer range of insights in this book. Let's finish now with some actionable takeaways, maybe some universal principles that we can draw from this deep dive into Charnley's classic text, things that apply more broadly, perhaps.
Yes, I think looking at this book, several core principles really stand out that apply well beyond the field of orthopedics, actually.
Absolutely. For me, one is the fundamental importance of understanding the underlying principles and mechanics of any system, whether it's bone healing or a complex business process, rather than just blindly following routine protocols. Charnley constantly probes the why.
Definitely. And tied right into that is the value of challenging conventional wisdom.
Yeah.
Resisting overly simplistic explanations for complex biological or systemic problems. We saw that with joint stiffness, it isn't just mechanical. Financial markets aren't purely rational either. Biological systems, social systems, they have inherent complexity that demands a deeper look.
And recognizing the critical role of those often invisible factors. The soft tissues in his case, the blood supply, the periosteum, the biological vitality, things that don't show up easily on initial scans or simple analyses, but are absolutely fundamental to the system's function and repair. Looking beyond the obvious data points.
Another significant lesson, I think, underscored by Charnley's own career and the legacy of his trust with the hip replacements, is the importance of long-term outcomes and careful, prolonged observation. True evaluation of any treatment, any strategy, any intervention requires patience and assessment far beyond just the immediate results. We need the long view.
So true. And finally, that recurring powerful theme, sometimes less is more. Recognizing when overtreatment or excessive intervention might disrupt the system's natural ability to recover or adapt and could lead to unintended negative consequences. That's a crucial skill, isn't it? Whether you're fixing a bone, managing a team, or designing a product.
Knowing when not to interfere aggressively can be just as vital as knowing when to act, finding that balance.
Yeah.
And, revisiting these foundational texts, like Charnley's, allows us to see how brilliant minds grappled with complex problems using the tools and knowledge of their time. It reminds us that the principles they uncovered through careful observation often hold enduring truth.
It really does.
It encourages us to be critical thinkers ourselves, I think, always questioning assumptions and looking deeper than the surface.
A truly thought-provoking point to leave you, our listeners, with. If you found this deep dive insightful, perhaps consider sharing it with a colleague or friend who enjoys unpacking complex topics. And please do leave us a rating on your favorite podcast app. It genuinely helps us reach more curious minds like yours.
It does indeed.
That's all for this deep dive into the foundational principles of fracture treatment, inspired by John Charnley's classic text. Thank you for joining us. You can find more deep dives wherever you get your podcasts.